Um, hey everyone, I am Mehak Pahwa. I'm a PGY2. Today my topic for the journal club is psychedelics and psychedelic-assisted psychotherapy. I chose this topic as it has been in the news more so recently. And then this particular paper is in the list of American Board of Psychiatry and Neurology certification articles. It was the most comprehensive review I could find on psychedelics. This is the work of a work group on biomarkers and novel treatments, which is a division of APA. It was published in 2020 in American Journal of Psychiatry. There have been a lot of updates since this article, but nothing has been this comprehensive since then. So I've tried to put in some newer updates in between, which is not from this articles, and I'll keep you posted when I talk about those. So coming to psychedelics, this was named by Humphrey Osmond, and psychedelic means something which is mind manifesting. So the story began with Albert Hofmann, who was a Swiss chemist in Sandoz laboratory in Switzerland. And in 1938, they started experiments and they made a couple of LSD compounds. They tested them on different animals, but nothing much was found, and the research sort of died down until 1943 when he made a fresh batch of LSD and he accidentally spilled some LSD on his skin. He was going home on his bicycle, and that's when he started noticing that the colors were too vivid, it was too bright. It was a kaleidoscope of colors. The buildings were moving, and that's when he realized that he came in contact with the chemical that made him have these vivid imaginations. It took him a couple of hours before he went back to his normal state, and then they slowly realized that this was LSD causing these effects. So Sandoz at that time started marketing LSD. It was a brief period when they were selling LSD as Delcid in the market. Um, then this eventually realized that this cannot be sold openly in the market, and this was mainly for psychotherapy and for experimental study. There were some brief early research in psychedelics at that time, around 1950s, and then soon the psychedelics were handed over to Timothy Leary and Richard Alpert from Howard University in 1960. So Howard at that time had a psychedelic research project, and they mainly researched psilocybin. Sandoz lost its patent for LSD around 1963, and that's when there was an indiscriminate dissemination of this brown acid in the US market. So the US government started getting worked up that this is not happening right. And in 1965, they started making the acts and laws, and it was 1970 when the Comprehensive Drug Abuse Prevention and Control Act was formed. So coming to the types of psychedelics, this particular review did not include dissociatives or deliriums. So ketamine is one of the psychedelics, but we will not talk about that since this review was not on that. It mainly talked about classic psychedelics and then the entheogens. So in classic psychedelics, which are mainly 5-HT2A receptor agonist, we have tryptamines, which are naturally produced, and it consists of psilocybin, DMT, and 5-MeO-DMT. Amongst the synthetic ones, we have LSD. The other group is entheogen. It is sort of an amphetamine agonist. It's a mixed serotonin and dopamine agonist. And then we have mescaline and MDMA in that category. So this paper conducted a search on PubMed and PsycInfo, mainly on the English articles using the term psilocybin, LSD, ayahuasca, and MDMA. It has articles from 2007 to 2019. There were around 1,600 articles, and that boiled down to 14 articles. They included RCTs, open label trials, and investigations in healthy volunteers, but all of them were clinical trials. And then the articles mainly are on mood and anxiety disorders, PTSD, substance use, and then the end-of-life care with anxiety and depression. Talking about, so when we have classic psychedelics and entheogens, how they affect our perception. So LSD, psilocybin, and ayahuasca, they can cause some changes in our visual perception. It can be slowness of the movement. It can be depersonalization, derealization. It can even cause some hallucinations or paranoid experiences. And then also some mystical experiences can be experienced. Amongst the negative emotions, they can cause anxiety, some mood lability, and then it is also said to increase our cognitive flexibility, creative thinking, insightfulness, and it can come along with some distractibility and disorganized behavior. Coming to MDMA, so MDMA does not cause any hallucinations as such, but it can cause some changes in body perception and some visual and auditory alterations. In the negative emotions, it can cause distrust, some hostility, and anxiety. Amongst cognition, it can cause some deficits in spatial memory, some mild impairment in the psychomotor tasks. So starting with psilocybin, psilocybin was mainly used by people of Central and South America for spiritual experiences pretty early on, but it was until 1950 that the Western culture was introduced to psychedelic mushroom when a couple went to Mazatec ceremony in Mexico, and then they came back and published this article in the Life magazine. And that is when the research on psilocybin sort of started. Psilocybin and psilocin were isolated from the mushroom called Psilocybe mexicana. And then its active metabolite is psilocin, and which is a serotonin transporter inhibitor, a 5-HT2A partial agonist, and then it binds 5-HT2C, 1A, and 1B in this descending order. The effects of psilocybin usually last around 3 to 6 hours, and the effects are dose dependent. Dose is usually between 0.3 milligrams per kilograms to 0.6. Starting with, when the research was given to Timothy Leary and Albert, so they did some initial studies, and this paper included 2 studies that were published. So one of them was a Marsh Chapel experiment or a Good Friday experiment. It was done in 1962. This was an experiment on 20 people from Protestant Divinity student volunteers that received psilocybin. So 10 of them received psilocybin and other 10 received niacin. So niacin was thought to be a placebo because it causes some facial flushing, but more so it is nothing compared to psilocybin. So the studies with the psychedelics always grapple with finding a placebo. So this was the first of those. They studied some mystical experiences, and they found that the study was positive for those. The people in the psilocybin group had much higher mystical experiences on an 8-category scale that they measured. Another study, which was sort of a polarizing study and led to expelling Timothy Leary from Harvard in 1960s. This was a Concord prison experiment, and it was an open label study. So this was to determine whether psilocybin-assisted group therapy could reduce the rates of recidivism after a period of incarceration, that is the ability to commit crimes again after being released from prison. So they studied it on around 32 inmates, and they did group therapy. They had a dose of 20 to 70 milligrams, and they did 2 group therapy sessions. They were pretty long group therapy sessions. And then it was followed by a series of psychotherapy sessions, but the psilocybin was given only in 2 sessions. So initially, when the paper was published, Leary said that psilocybin significantly reduces rates of recidivism. But later on, Doblin reanalyzed, and he said that the rates were not significantly lower than any general prison population. So he became a polarizing figure and then was expelled from Harvard following a lot of changes that happened around this time. As we all know, every drug is different for every person. So Timothy Leary gave this concept of set and setting for psychedelics. And he said, the non-pharmacological factors help shape the psychedelic experience. A set is an internal individual characteristic, so it will be different for every person consuming the drug. And the setting is very important. It is the environment in which the drug is consumed. So psychedelic researchers talk about that it is very different if you take psilocybin or MDMA in a rave party by the beach or by your friends, but it's very different when you take it in the therapy session, when you take it in a protected environment. Before going on to the papers that this review is talking about, let me give you a glimpse into what psychedelic-assisted psychotherapy usually is. Every paper talks about this. I'm not going to talk separately in each of the papers, but just talk broadly about this. So psychedelic psychotherapy uses a spectrum of psycholytic and psychedelic therapy. Psycholytic is mainly psychoanalytic. It is divided into three phases. First phase is a preparatory phase in which a patient is, exploring his life history. You get all the information. You form a therapeutic alliance with the patient. You educate them about, what they can expect and how this is about. So every study had few preparatory sessions with the patients. Then comes a medication phase. I'm going to talk more about this in the next slide. And then there is an integration phase. The integration phase is the last phase when the therapists work with the patient to interpret the content of their psychedelic experience into a meaningful long-term change, and then talking about the ideas they had during the session. Coming to the medication phase. So this picture is from a John Hopkins paper by Johnson et al., and this was one of the initial papers in 2008. So all the centers that are doing the psychedelic research are using more or same set right now. So this is administered in a comfortable room with a recliner bed or a chair. And after they consume the drug, the patient is encouraged to focus on inwards, and then they can listen to music, they can wear eye shades. So there are two therapists in the room, and they usually have a male and a female therapist. There were some initial studies where it was documented that there were some abuse during the sessions. So to remove that error, they always have two therapists in the room. It is usually lasting around 6 to 8 hours. And then the therapist is just sort of listening to the patient. They maintain a very non-threatening, a neutral therapeutic stance. They facilitate safety, trust, and openness, and they drive the experience, but they are not doing any CBT or any assisted therapy. This is usually not evidence-based therapy during the sessions for most of the studies conducted. Also, they say it's more of like rent a friend when they're doing the psychedelic therapy. So when this research scientifically started, I'm talking about the first few papers, this is one of the set from Carrot et al. This study is from Imperial College of London. This was one of the initial studies that sort of formulated how it's going to be done. So I'm showing this picture of their plan, and most of the studies use the similar sort of the methodology. So there is a telephone screening that was done in this, and then you take the preparatory stage, you take the information and the baseline assessments. This particular study did the baseline fMRI in the preparatory session, and then there were two phases. The first one was a low psilocybin dose at around 10 milligrams, and then a week later, they gave another psilocybin dose, which was a higher dose of around 25 milligrams. Then they did a post-treatment fMRI study, and then they followed up 1, 2, 3 weeks, and then 5 to 7 weeks after this. This study was on major depressive disorder. They recruited around 12 patients, so it was a small subset, and they included patients with treatment-resistant depression who had a score of more than 17 on HAM-D scale. And their measurement was with the QID score. And as you can see, so the baseline score is high, and then after a week, there was a significant drop. It had a significant effect size, and then the drop was maintained up till 3 months. So this study had another paper published, which was on the fMRI scan. Before I talk more about the fMRI, what critics say, I'll just talk a little bit about that. So people who criticize fMRI studies say when a patient is in an MRI, a patient is never at the resting state. So we have to take these studies with a pinch of salt. When there is a lot of noise going on, the MRI machine itself makes a noise, and then there are a lot of things going on in our mind at that time. So we don't know how much resting stage when we say we take a recording before the session began. This particular study talks about that one day after the psilocybin session, they showed some patients expressions from the Karolinska emotional faces, and they found that the psilocybin had increased amygdala response to the fearful component. And as you can see in this picture, so there's amygdala response is increased. And so they had two things that they proposed. One is that the action of psilocybin is different than an SRI because it's increasing the amygdala activity. And the second thing that they said was psilocybin acutely disrupts default mode network connectivity. It induces a temporary neuroplastic state that can make an individual more susceptible and receptive to cognitive functions. So this is what the studies are banking on, a temporary neuroplastic state. So that was about MDD. Coming to other studies that were included in this paper are anxiety and depression with comorbid cancer. So this is an article from JAMA Psychiatry in 2011. This was also a small study on around 12 people with age 36 to 48, and they all had stage 4 cancer with anxiety. They used niacin as the control, and then each subject acted as his or her own control. What they showed was the state trait anxiety scores decreased. So they used two measures. One was the self-reporting, which did not show any change. But the other, the STAI trait score, it had a drop after a month, and the drop was sort of maintained after this. Even by 6 months, it was not where they were at baseline. Following this study, there were few more on anxiety and depression with comorbid cancer. So John Hopkins has been leading in all the studies, and this was a paper from 2016. It was published in Psychopharmacology Journal. And as you see, this paper used psilocybin 22 milligrams as the dose, and they had an active comparator with 1 milligram of psilocybin, which was an active control. And then they made the participants cross over dose, so the controls got the actual dose later on. And then, as you can see, there was a decrease in HAM-D scores, BDI, HADS, HAM-A, and anxiety. So everything had a dramatic decrease in the study. And then they said that the decrease was maintained even 6 months after. At the same time, NYU conducted another study on anxiety and depression with comorbid cancer. They used niacin, and they had around 29 people. They did the crossover around 7 weeks. So this study had, as you can see, the top graph, the purple one is the psilocybin group. So the psilocybin group had decrease in their depression, anxiety, BDI scores, STI state. So everything is lower, whereas the blue one is the one that received niacin, which does not have much changes. The second graph is when the niacin people got switched over to the psilocybin group. And that's when you can appreciate the decrease started happening. So this was a positive study, and they said 6.5 months after the active psilocybin intervention, around 60 to 80% still maintained their response status, which means they had their decrease, more than 50% decrease in their scores, even after 6 months. So there has been some preliminary evidence in substance use, and one of the first studies was done at Johns Hopkins by the same group in 2014, and this was a study on smoking cessation. This was a slightly different study because they used CBT. So they formulated the plan. They did CBT, like 4 sessions of CBT. Then they set a target quit date, and then psilocybin was given at week 5 on the quit date. And then another one was given on week 7, and they had option to take a third psilocybin session at week 13. The first session, the first dose was 20 milligrams, and then the third dose was 30 milligrams, and the fourth one was also 30 milligrams. This study actually studied smoking abstinence by measuring exhaled carbon monoxide and urinary cotinine measurements. So this was an objective measurement of the study, and they found around 80% of the candidates were verified abstinent at 6-month follow-up, and then 67% remained abstinent at 12 months, and then 9 of them were even abstinent at 2.5 years later. Another area where this has been studied is alcohol. So this was a study in University of New Mexico, and they included patients who were heavy drinking, and that was like 2 binge drinking days in the last 30 days. This also had a slightly different methodology. They had 7 sessions of motivation and enhancement therapy, then 3 preparatory sessions, and then 2 psilocybin-assisted psychotherapy sessions. They used around 0.3 milligrams per kg as their dose, and the second one was 0.4 milligrams kg as their next dose. So they gave 4 sessions in between, and the next 4 sessions after the second dose. However, this study did not have any measurements, which was measured from scales, and this was a self-reported study. So we do not know how much accurate this was. Then there is an interesting subjective experience that Johns Hopkins did around 2,000 people. They did an online survey, and then they talked about if, whether taking psilocybin mushroom, they ever had a bad trip. They had anxiety, fear, or distress. And they found that 39% of the population reported that their experience was one of the most challenging experience of their lifetime. 24% said that the symptoms lasted more than a week, 10% had symptoms that lasted more than a year, and then 7.6% had to take some professional help. Coming to this, so Dr. Wong asked me, do you know how patients feel when they take it? Does any of the paper talks about it? So this paper did not have any information about the subjective experience. But there is a recent study that I included. So this is the JAMA Psychiatry paper from 2020. This study had an online supplement which talks about the subjective experience, what patients feel like when they take psilocybin. So I thought this was interesting, and I'm putting this in here. And 92% patients said that I felt like crying. They felt sad, there was emotional and physical suffering, their heart was beating fast, their body was shaking, they had a pressure on their chest. So it was grief, loneliness, despair, anxiety. So a lot of feelings, I would not say very pleasurable, but this was a very comprehensive subjective experience that they documented. So that was about psilocybin. Going to the next one, this is LSD. This is slightly different. It's an ergot derivative, and this has been used for psychedelic, spiritual, and mystical experiences. It is a partial agonist at 5-HT2A, and it also binds to 5-HT1A, 2C, and 2B in the descending order. Another thing that is different is binding at a dopamine receptor, and it releases glutamate in the frontal cortex, increases functional connectivity and excitability in thalamic and cortical structures. So the studies on LSD are mainly Swiss studies and have been done in Switzerland. This one is in 2014. This was an RCT which was LSD-assisted psychedelic psychotherapy. And there were 12 patients that they recruited. All of them had a chronic illness like malignancy or Parkinson's disease, celiac disease, or a chronic illness like ankylosing spondylitis. This study tapered off antidepressants or anti-anxiety medications for all the patients. So there were some drop-offs before whatever they included because they could not handle tapering off the antidepressants or anti-anxiety medications. They had 2 sessions which were LSD assisted, and they used a dose of 200 micrograms. And then the other group, they used around 20 micrograms. So that was like an active placebo that they used at a lower dose. As you can see in this graph, this black is the experimental group, and this is the active placebo group. So people who got a lower dose had some increase in their anxiety. This is the trait anxiety, and this is the state anxiety. And then when these people in the active group had a crossover to a higher dose, they had decrease in their anxiety, both the state and trait anxiety. Another interesting study on LSD is again from Switzerland. This was published in 2015, and another one was in 2018 from the same group. So this was in healthy volunteers. So it's difficult to do here on healthy volunteers, but this was an RCT crossover study with single dose of 200 microgram of LSD. 1 and 12 months after the LSD administration, they measured. So one was 1 month after, and then the follow-up was 12 months after. They used a lot of persisting effects questionnaire, and then they studied positive attitudes, altruism, and that's where these scales, you can see a drop in all of them, most of them. And then the study said that around 71% patients reported LSD experience as the 10 most meaningful experiences in their lives. And then the 5 said that it was the most spiritually meaningful experiences. One study that's again a Swiss study in 2017 was an RCT that studied the LSD. It was an fMRI study. Interestingly, this is different from the psilocybin that I mentioned earlier. So they took around 20 healthy subjects, and what they found was LSD produced decrease in the amygdala activity to fearful stimuli and then impaired recognition of fearful faces. It also noticed a decrease in the right medial prefrontal cortex compared with placebo. So the mechanism that they are proposing for LSD is that it modifies the processing of bias towards negative stimuli, and that can play a role in depression and anxiety. And LSD might be useful for reducing perception of our negative emotions, and then decreasing our cognitive deficits and facilitating a therapeutic alliance. So this is different from how psilocybin is proposed. And then another fad, microdosing LSD. So a lot of things have happened since this paper was published. But what is microdosing LSD? It is the practice of taking doses below the perceptual threshold at 3 to 5 days interval in an effort to trigger a cellular response. There is no scientific evidence to support the practice of microdosing. There was a latest paper on the same thing, and I think it was also very inconsequential, and there is no evidence which is pretty strong to support this. It is the LSD doses which are used at around 13 and 26. This study that this paper included had 20 people, and they measured minimal effects on cognition and creativity. There are ongoing studies, so we don't know what's going to come out of this yet. Going on a few more of the psychedelics, I'm going to be brief on others because we don't have them here. This is ayahuasca. This is a combination of 2 ingredients, complicated to pronounce. They are found in Amazon basin, and it inhibits MAOA. It prevents peripheral degradation of DMP, It is a serotonin transporter and a norepinephrine transporter inhibitor, and then it works on the same mechanism and as a 5-HT1A agonist. Also has efficacy on 2A, 2C, and 2B. The studies that we have for this compound are mainly open label, and they are mainly from Brazil. That's where it's available. And it's on major depression with a significant decrease in HAM-D scores according to the studies. But at the same time, it is open label. Patients know what they are taking, and then it's questionable, hasn't been reproduced in other areas or other countries yet. Then the next one is MDMA. So MDMA is an amphetamine analog. It is slightly different than what we talked about until now. It is also called a penicillin for the soul. It is the soul of ecstasy and the rave parties. It works by releasing monoamines, serotonin and norepinephrine transporter reuptake inhibition, monoamine oxidase inhibition. It is also a partial agonist at the serotonin receptors, 5-HT2A, 1A, and 2C. And then it is also known to increase the blood concentration of oxytocin. Interestingly, the studies that were in this review are by the same group. It is a group somewhere in California, and all these studies were sponsored studies. So somebody paid for these studies to be conducted. These were done in patients on PTSD. And then the first one was a randomized double-blind crossover. They used lactose and they used 125 milligrams. There was a follow-up study for the same paper, and there was another one which used 3 doses, 30 milligrams, 75 milligrams, and 125 milligrams. They all reported significant reduction in the PTSD symptoms as measured by CAPS score. And this is an area where a lot of changes, where a lot of studies are going on in the PTSD population. So since this paper, there has been tremendous research. If you search psilocybin, you will get 10 new papers every day. There have been some major ones. There's one on depression, then microdosing, and then global integration after psilocybin. And there's a paper on psilocybin versus escitalopram for depression. So this is like apart from the review that I'm talking about, there is in the JAMA Psychiatry, there's a special communication as a clinical review and for education purpose. So this was interesting. There are like 25 states that have considered 74 bills, and 10 bills were enacted and 32 were still active by the time this paper was published. And the authors sort of talk about how cannabis has, like the cannabis graph, when the cannabis was legalized in one state, and then it took certain number of years for many states to follow that, that the same thing may happen with psychedelics, and they assume that a lot of states will legalize psychedelics by 2034 to 2037 if they follow the trajectory of how cannabis has been. So Oregon has been the first state to legalize psychedelics. And this was this year, January 1, in New York Times covered this full news on legal use of hallucinogenic mushroom begins in Oregon. I was reading it, and I may be wrong, but just some snippets from it. They had like a huge group of mental health professionals that are undergoing this. So they will be taking part in the therapy. And then there's a psychiatric nurse who's leading this. But they are legalizing it. And there are concerns that if this will be sold in the same shop as cannabis is, how this is going to go. There is a lot of potential for abuse. It is freely available now. Oregon has said that the therapists that can do this therapy, they can just take a 20 hours online training. They need not be trained in psychiatry. They need to have some basic undergrad degree in science. And then the patients who can undergo this, they do not need any medical screening. So just briefly touching on some of the things that are really concerning. Again, Dr. Wong told me about this. This has been published in December of 22. This is a paper that talks about a young girl who is around 35, very high functioning girl. She was in the Western Coast, was an accountant, was treated for like some depression and anxiety, only was on venlafaxine, and then she tried psilocybin because her friends told her to. She had a very good trip, so she had some of the dose left, and then she took it again. Following that, this girl had a prolonged manic episode with psychosis. She was paranoid. She was hospitalized multiple times. Only thing positive there was a family history of bipolar in one of the siblings, but she was stable on her venlafaxine, never had any episodes, no hypomanic episodes. And then what followed after this was a prolonged period of psychosis and mania. She ended up being marinated in a lot of antipsychotics. And then what this group talks about is she was worked up for NMDA. She had everything under the sun that she had not tried. They did some plasmapheresis. They tried every medication possible. And then when she came to this group, so Dr. Nemiroff talked about, she was so anhedonic that to the extent that she said the puppy that she raised from birth, even if that puppy came under a truck, she would not feel a thing. And they said that she had no emotions left in her at that time. So this group was debating trying ECT versus a dopamine agonist, and they somehow put this girl on pramipixole and increased it around 4.5 milligram, which is working for her. I don't know what's the theory behind pramipixole, but this is a case severe enough to have some adverse effects in patients that we can anticipate if this gets legalized, what we can be looking at. Interestingly, there are some things which have been proposed. So some of the centers have raised huge grants as of now. I heard a talk where Dr. Nemiroff was saying he got $3 million within a span of 8 months to do the research on psychedelics. And they are talking about how we can make it more meaningful. And they've been talking about if psychedelics are coupled with TMS or RTMS, if psychedelics are coupled with evidence-based psychotherapy, if they're covered, if they're coupled with CBT. There have been some innovative designs that they're thinking of, treating patients with CBT, and then the patients that fail on CBT will be then given psychedelics. So they are finding more ways of coupling evidence-based treatments along with the psychedelic therapy, and which can lead us to a better answers, I would say. So that is all that I had. And I would like to end my presentation with this. Thank you for listening, and I think we can open up for questions now. I will do the slide share. Dr. Wong is raising. I don't know how to promote him as a panelist. Pooja, can you help with that?
He's been invited.
Okay.
All right, Dr. Pahwa, really nice extensive review on this subject. I think it's a very important subject. So yeah, the question still is it's kind of the same. So what is the medicine? What does this type of drug do And then why do we think that's treatment? Hello?
Uh, I'm sorry, can you repeat that? What psychedelics? In
Yeah, what does psychedelic do to the person? And then so why do we think that's treatment?
So what this paper is talking about is that it produces a transient neuroplasticity, and then they give you a sort of a setting to reprocess your trauma.
Uh-huh.
And they are saying when it's coupled with psychotherapy, so in PTSD, it can help you reprocess the trauma. And as one of the authors said, it is like, you're refiling your brain and then you are compartmentalizing that trauma into a different folder where it is less accessible. These are not my words, so I don't know what they do, but
I know, but so if they're talking about neuroplasticity, sort of like how does that guide you on what kind of population you can give this medicine to? So would you give it to a like an elderly person or young person? Sort of like what's our so we treat a lot of people, become psychotic on this kind of psychedelics. So sort of what's your thoughts on that?
oh, absolutely, I agree. I'm not very pro this, but at the same time, it's very interesting. They think that the scope of the use of psychedelics will be limited to more of research or in a setting because it's not going to be practical to have a 6 to 8 session with the two psychotherapists in the room. But certainly there are patients that, we need to try more and figure out where it will be beneficial. Whatever we have is limiting, and where the rate at which we are progressing is another concerning topic if it gets legalized and then creates another epidemic, similar to what, there was a recent paper that was talking about the opioid epidemic, and they think that this will be similar to something like that, or something like cannabis. So, now we are grappling with cannabis-induced psychosis a lot. So whether this is going to lead to another epidemic.
Yeah. So another question is like I think everybody is kind of proposing with 1 to 2 treatment, you will have long-lasting changes in the patient. And then, but on the other hand, sort of what about the vicissitude of life? Basically, life will throw you a curveball, and then you will have up and downs in life. Sort of like is this like just one dose? You're fine for the rest of your life, or if they like sort of like you will face other stressors in life. In the are you gonna fall apart again? That kind of.
Yeah, absolutely. I think all of the studies, majority, they have only studied up till a year after the dosing. So I don't know how they can extrapolate it to forever.
Yep.
And then it's always life. But yeah, that's limited.
Yeah. Very comprehensive review. Thank you so much.
Thank you, Dr. Wang.
If you look at the feelings that you had for the psilocybin, I guess, adjunctive psychotherapy, they're all extremely negative. So maybe the long-term results from this treatment is, at least nothing's as bad as psilocybin adjunct therapy. So they can get through life because they're like, oh, well, it's not as bad as that.
That's why it's therapeutic, huh, Dr. Ives?
Yeah, that's it.
Yeah. But they're trying to like get in more comprehensive and then trying to put in like CBT or other therapies which are more evidence-based to see how that goes. But I don't know.
But I think Nemerov wrote an article. The title is sort of who's assisting who. Sort of is it therapy assistant the psychedelic treatment or psychedelic assistant psychotherapy. So in that article, he was arguing the psychotherapy during psychedelic sessions is just supportive, just trying to help you go through this strange experience. And then there's like no CBT, no psychodynamic, no intervention involved, that kind of thing. So that was his take on this kind of treatment.
Mhm. Any other questions?
Well, this is more of a comment than a question, but it seems strange to me that they're presenting this as a treatment for post-traumatic stress disorder, just based on the fact that, a lot of times we pay attention to what use are preferred by different groups because we think that maybe there is some sort of attenuation to it, with the bipolars tending to like to drink and use marijuana, and it's ways of slowing their brain down, for instance. Using a psychedelic in a PTSD patient seems kind of counterintuitive, and I've never really come across anyone with like a severe case of PTSD that ever said, "Oh man, I love LSD. It's great stuff. I use it all the time." But the concept behind it kind of makes sense because we do, I think pramipexole you had mentioned briefly. There is quite an extensive literature behind pramipexole for refractory depression, both unipolar and bipolar. We've been using it at the Depression Center for probably 6 or 8 years. Dr. Wright came across the study where people had failed up to 5 different treatments. There was still like a 50% response rate, which it does seem to correlate with what we see in clinic. Well, it's a dopamine agonist, right? So aripiprazole, cariprazine, brexpiprazole, they're partial agonists of dopamine. So these are serotonin agonists. And so it is something that you would think theoretically could be stronger than a serotonin reuptake inhibitor because it's actually going out there and hitting it. But of course, serotonin 2A antagonists are the key component of atypical antipsychotics. So I think you would have to be much more careful screening for a history of bipolar psychosis, et cetera, in any patient that would be considering this kind of therapy if it does come to fruition. I think the other part of this is that, like the one case report for the person on venlafaxine, obviously MDMA and ayahuasca having a MAOA inhibition, you would never want anybody on an antidepressant to use them. And I think that there might be some trend going forwards to taper off of the unsuccessful antidepressant therapy before trying a hallucinogen for that reason as well, because you'd be at a higher risk for serotonin syndromes, I would think, as doing the combination therapy.
Yeah, interesting point. Thank you for that, Dr. Scheinbachler.
I put a few links in the chat. There's a interesting and somewhat sordid history of the background on this and its use in the U.S. in particular with regards to the studies you'd mentioned at Harvard. Ted Kaczynski was actually one of the subjects in the Chapel study who went on to fame as the Unabomber. The CIA had a lot of documented involvement with the thing called MK Ultra and some studies where hallucinogens were administered unknowingly to a number of subjects, and those tests were quite controversial, and I think in the 70s resulted in a lot of legislation to kind of rein in the CIA's uses. There's a book by a journalist named Michael Pollan who's written a number of things. He's not a clinician, he's not a scientist really, he's just a better than average writer, but documenting sort of some of the same things and targeted more a lay audience, but is worth checking out as well for those who are interested further. A lot of very interesting work was done around addiction, curiously enough, as mentioned, and also end of life. And if you think about the spiritual aspects of the use of hallucinogens in various native religious practices, that shouldn't be all that surprising. And the spiritual aspect, even in addiction treatment of things like AA and 12-step programs, they talk about the spiritual aspects of hallucinogen use. So that shouldn't be surprising either, I wouldn't guess.
Mm-hmm. Absolutely. Dr. Will Wang has a question, and he's asking, is there any comparison between psilocybin only versus psilocybin with therapy that I know of? So as far as this review goes, I think all the papers have used psilocybin with therapy, and then their take on this is that psilocybin in itself does not work. They feel it's the therapy or that setting where you are taking it and you're able to process your trauma is the thing that is working, not just the drug itself. So I'm not aware of if we have studies with only psilocybin and without the setting. I'm sorry.
Just going off that, I also don't think there are any papers out there that kind of examine people who continue to use hallucinogens after assisted therapy more illicitly, and if that has any impact whatsoever. But it's also my understanding that at least early experiments, the people undergoing this assisted therapy already had exposure to hallucinogens. At least most of the participants did. I don't know if that's still kind of what's going on with more recent experiments or not, though.
Yes, so they've been saying that most of the patients who are enrolled in the studies have had some experience on psychedelics before, and they wanted to do the study and wanted to be a part of the experiment. And there's another thought that they're saying a lot of people are going out of country to places like Costa Rica or Mexico and then have these experiences, and they're coming back and they think they should have this legally available here, for trial or for their mood. And then they've been pumping in a lot of money for the research. So it is still not clear, how much is the true research versus the sponsored research. Pharmaceutical companies, they had like 700s of millions that they've put in the research, whereas NIH only had $4 million invested in this research, like in the country. So it's still not where we want it to be.
Yeah, so yeah, I'm sorry. The point I was asking, trying to drive at is maybe we should choose our patient population carefully with this psychedelic treatment. Maybe for an elderly person, they're very fixed in their life. Oh, they have cancer, they're facing end of life issues. They need that plasticity, they need that flexibility. And then for some young person, maybe they're at higher risk, to develop psychosis. Maybe we should, avoid giving them this kind of treatment. That just, yeah, my 2 cents.
Any more comments or questions? I would like to thank Dr. Wong and Dr. Lipman. They helped me a lot for this, and I truly appreciate that. Thank you, everyone.